Rachel, let's hear from you. Thank you.
Hi, everyone. I hope you can hear me. I'm Rachel Grace. I'm a pediatric hematologist and clinical researcher at Boston Children's Hospital and Harvard Medical School. And I want to thank you all for having me here today virtually, and for the organizers of Thrive for inviting me to be a part of this meeting. And I think this is an important and exciting landmark and milestone in the progress that we're making in pyruvate kinase deficiency. I'm just going to share my screen to show slides. Hoping you can see my slides. Maybe I'll get a thumbs up from other people in the room to let me know that you can see them. Before I get started, I wanted to show you my disclosures. I do receive research funding and consulting from Agios Pharmaceuticals, and I'm a member of the PK Deficiency Advocacy Advisory Council. Before we talk about pyruvate kinase deficiency, I just wanted to take a minute to talk about how healthy red blood cells make energy. Healthy red cells are in the shape that's shown here on the right. This is a biconcave disc, it's called, which looks like a squished sphere or a donut where the hole doesn't go all the way through. And the shape of the red cell is critically important because it allows the red cells to traverse very small capillaries or blood vessels in the body with the ability to maintain its shape. And the red cell needs energy in order to maintain this biconcave disc or this shape. And the way that the red cell makes energy, as Dr. Nathan just mentioned, is through a process that's called glycolysis. And glycolysis is the process where the body or the red cell converts energy from glucose or sugar into ATP or energy. And as Dr. Nathan mentioned, pyruvate kinase is part of a key step in the process of glycolysis where energy is produced. And the red cells need to rely on glycolysis because, unlike many other cells in the body, they don't have other ways of making energy through a nucleus or through these organelles called mitochondria. So what happens to red cells when there's pyruvate kinase deficiency? So in the setting of not enough pyruvate kinase, the red cells can't make enough energy or can't make enough ATP and break apart. So rather than lasting the 3 months or 120 days, they last for just days or weeks and undergo a process called hemolysis, where the red cell fragments and falls apart. And this leads to many or most of the symptoms and complications related to pyruvate kinase deficiency. I just want to mention too that with this deficiency in pyruvate kinase, there's actually a backlog of earlier parts of glycolysis, the earlier steps in the pathway. And one of them is called 2,3-DPG or 2,3-BPG, which is a metabolite that helps the body or helps red cells offload oxygen into the tissues. And in people who have pyruvate kinase deficiency, there's this buildup of earlier metabolites, including this one, which increases oxygen off into the tissues. What happens to red cells in the setting of pyruvate kinase deficiency? Well, I mentioned that red cells will break apart. Instead of lasting 3 months, they just last days to weeks. And this causes a number of lab manifestations, which are listed here. And that includes lab manifestations of increased red cell destruction or hemolysis. And that leads to generally a low hemoglobin, which most people is equivalent to anemia. And in addition to that, when there's the breakdown of red cells, there's the release of some products inside the red cells, including bilirubin. And increased bilirubin level is what leads to the scleroicterus, or yellow of the eyes, or jaundice, yellow of the skin. There can be also an increase in a metabolite that's called lactate dehydrogenase, or LDH. And there can also be a lab finding with a decrease in a protein that's called haptoglobin. And that's because as the red cells break apart, they release hemoglobin, and this binds to this protein called haptoglobin, leading to a low level. So you have this destruction of the red cells, and with that, the body tries to compensate by making more red cells from the bone marrow, the factory for all the red cells. And so the red cells are produced by the bone marrow readily as red cells are being destroyed, and that leads to this increase in the youngest red blood cell count called reticulocytes. And so you have this balance of destruction and production of red cells. And in that balance, we say there's compensated hemolysis, or a balance or a set point where each person has that defined hemoglobin that is a combination of production and destruction. And it's quite variable between individuals with pyruvate kinase deficiency, where that balance is or what the hemoglobin is at baseline. On the right here, you can see the process by which red cells try to circulate through the body, and in particular, circulate through those small blood vessels in the spleen. And without that biconcave shape, without that donut shape of the red cells, they have trouble traversing these very small blood vessels and fragment, leading to these laboratory changes. What causes pyruvate kinase deficiency? Well, it's an autosomal recessive condition. It's a genetic condition. And you can see in the upper left corner a Punnett square that shows you how recessive traits are inherited. So if the capital A is the healthy copy of the gene and the lowercase a is the affected or a variant copy of the gene, you can see here in the case of two carriers, so someone who has one copy of a healthy gene and a variant gene, and another person with a copy of a healthy and a variant gene, that there's a 25% chance of having a child, or a 1 in 4 chance with a copy of an affected gene from each parent. And that's what's shown in the figure here, where two partners are together, and there's a 25% chance of having a child who has pyruvate kinase deficiency if they are each carriers. I'm often asked, well, if I have pyruvate kinase deficiency, but my partner doesn't, then what's the chances that I'll have a child who has pyruvate kinase deficiency? And really, there's two possibilities here. And the most common is shown in the upper left part of the screen. That's the case where there's an affected partner, so the two lowercase a's, and then the other partner does not have pyruvate kinase deficiency and is not a carrier of pyruvate kinase deficiency. And in that scenario, every child will be a carrier of pyruvate kinase deficiency, but no child would have pyruvate kinase deficiency. And that's what's shown in the figure here too. There's a less common scenario, but one that Dr. Nathan just mentioned, where one partner has a pyruvate kinase deficiency, and then the other partner happens to be a carrier. So they're not affected, but they just happen to be a carrier. And in this case, there's a 50% chance of having an affected child. So this is a scenario where it's worth consideration of whether a partner should be screened for pyruvate kinase deficiency with a genetic test to better understand what the likelihood of having an affected child with pyruvate kinase deficiency is if you have pyruvate kinase deficiency. I just wanted to pause here just to mention that about registry studies in pyruvate kinase deficiency. A lot of the data that I'm going to be showing in the subsequent slides and as part of this discussion comes from registry data. And we had a registry called the Pyruvate Kinase Deficiency Natural History Study that I think many of you participated in. And this was an observational study, meaning we collected information about somebody's history when they enrolled in the study over their lifetime. And then we looked over time, over 2 years, to better understand what happened after they enrolled in the registry. And we enrolled 254 people, mainly from North America and Europe. And that study is completed, but there's currently another open registry that's called the PEAK registry. And I put the website here because that registry is currently open to continue to collect information about people who have pyruvate kinase deficiency. And just to mention the importance of this is that this is where we've understood about what are the symptoms people have, what are the complications that people have encountered, the rare ones, the common ones, and how are people managed and what are the outcomes of those management decisions. And these are the things that help us to understand more about pyruvate kinase deficiency to help improve our care over time. What are the gene changes that cause pyruvate kinase deficiency? So I mentioned already that it's autosomal recessive. Most people actually have two different PKLR mutations, two different variants in their gene to explain why they have pyruvate kinase deficiency. And there are over 300 described mutations currently. So that means most people will have a combination of gene changes that are unique to them. There's some more common gene changes, but they're often combined with another gene change that's unique to that person. The majority of changes in the gene are called missense changes, one amino acid change, more subtle changes to the protein. And the other types of changes are more drastic or dramatic changes to the genes. And those are shown in the different colors here and can have more dramatic effects on the way that the protein is made or the half-life of how long the protein lasts for. Most of the mutations are rare. And interestingly, in our registry studies, we found that 20% of people have a new gene change, one that hasn't been described before. And this leads to difficulties in making a diagnosis of pyruvate kinase deficiency. How is the diagnosis of pyruvate kinase deficiency made? Well, first, we recognize that somebody has a hemolytic anemia. Their red cells are breaking down and they're making more red cells to compensate for that. And we're suspicious that it's congenital, something they might have been born with, even if they're an adult when it's first recognized. The first thing we do is exclude more common causes of hemolytic anemia since pyruvate kinase deficiency is rare. And once we've done that, there are two tests that we typically do to diagnose pyruvate kinase deficiency. The first is to look at the pyruvate kinase enzyme activity level, which is a blood test. This test is difficult to do. It's difficult to send the tube in a way that the specimen can be properly processed, and it's a tricky assay to do, a tricky test to do in the lab. It may not be available to everybody in different parts of the world. It's difficult to do in the setting of transfusions because then you're going to be measuring the activity of the enzyme in the transfused red cells, not in the person's red cells. It's low in people who carry pyruvate kinase deficiency, so it won't help you to tell the difference between someone who has it versus someone who's a carrier. And you may need to get other red cell enzymes checked at the same time as the pyruvate kinase enzyme because it's dependent on how old the red blood cell is in terms of the interpretation of the level. So we will typically do genetic testing in addition to the enzyme testing. And that's also often a blood test, although it can be done with saliva or swabs of the inside of the cheeks. And genetic testing can be very robust, but it also has some nuances to it, including there's a high rate of newly described mutations. So sometimes it's not clear, is this just a normal gene variant that happens in the population, or is it one that could be part of having pyruvate kinase deficiency? And it's also expensive, and so it may not be available in all parts of the world. In the United States, you can now get genetic testing without cost. How common is pyruvate kinase deficiency? Well, this is a difficult question to answer because it hasn't been studied rigorously, but we know that it's rare. The prevalence of clinical disease of people who have symptoms of pyruvate kinase deficiency, and we recognize that's what they have, is about 3 per million. We know there's higher frequencies in certain populations, for example, where there's a founder effect, where there's common ancestry for a certain population. And we know too that it's more common in areas with selective pressure from malaria. However, we also know that the estimated prevalence, so what we would guess was how often we see this condition, is higher from genetic studies than we actually see in clinical practice. And it's not clear why that is. And people have lots of theories, including maybe there are people who have mild pyruvate kinase deficiency and they're diagnosed with another hemolytic anemia that's more common, have sort of the wrong diagnosis, or it's just not even recognized that they have hemolytic anemia, or maybe it's so severe that the pregnancies don't make it to delivery. And it's just really not clear why there's this disconnect between what we see in practice and what's predicted based on genetic studies. I'm going to switch here because we talked about healthy red cells with pyruvate kinase deficiency, genetic testing, and how to diagnose pyruvate kinase deficiency. And I'm just going to take a minute to talk about symptoms because you're the experts in the symptoms. I'm not the expert in this. But just to mention that there are lots of different signs and symptoms that can happen in newborns with pyruvate kinase deficiency, and it can be quite variable, including newborns without any symptoms. It's not recognized they have a hemolytic anemia at the time of birth, and those are babies who get diagnosed later in childhood or even adulthood. But there can be many symptoms that happen even before the time the baby's born, and those are listed here and can include being born early or prematurity, body, having fluid in parts of the body that you don't normally have it around the lungs or in the belly before the baby's born, called hydrops fatalis. The baby can be small, that's called intrauterine growth retardation, and it can be recognized that the babies need transfusions even before they're born, called intrauterine transfusions. Newborns can have a range of more severe clinical findings too, that sometimes aren't easy to recognize as being related to pyruvate kinase deficiency. And that includes things like high pressure in the vessels that go to the lungs, called pulmonary hypertension, having a rash where blood cells are being produced as part of the rash, called extramedullary hematopoiesis, or a blueberry muffin rash. There can be severe liver disease at the time of birth, even requiring liver transplant. And there can be stroke or coronary artery disease, really what people would think are sort of unusual manifestations of pyruvate kinase deficiency. But actually, we see those at the time of birth. And jaundice is the most common symptom at the time of birth, affecting most children who have pyruvate kinase deficiency, although not everybody, and requiring phototherapy for many, and sometimes exchange transfusions to remove the bilirubin to avoid a problem called kernicterus, where the bilirubin is toxic to the neurologic system. And if labs are obtained around the time of birth, we see the different lab changes that I already mentioned. And I also just mentioned too that there sometimes can be a worsening of anemia in the first month or 2 or 3 after birth, because there's normally anemia during that time for every baby, every healthy baby, called a physiologic low hemoglobin. But this can be worse in patients who have a congenital hemolytic anemia like pyruvate kinase deficiency. And it can be hard to judge if somebody needs ongoing transfusions or they just needed it during this tricky time. What are the symptoms in adults and children? Well, they can also be quite variable too, as you all know. And anemia the symptoms and manifestations of anemia can be variable, and people with different hemoglobins can feel quite different from one another. Some of the symptoms that people might experience include things like pallor or fatigue related to their anemia. Young children, their appetite and growth can be affected by anemia. Young children and adults can have the effect of poor focus or concentration because of anemia. There can be an impact on your ability to make it through the school day or the work day, poor exercise tolerance related to anemia. And then there can be episodic worsening of those symptoms in the setting of acute stressors like viral infections or pregnancy. And sometimes there can be a worsening that happens also in an ongoing way related to age. We know too that jaundice and scleral icterus have a major impact on everyday quality of life in young children and teenagers. There can be unwanted attention or bullying related to the jaundice or the scleral icterus. And there can also be manifestations with gallbladder disease leading to the need for surgery. And then splenomegaly, an increase in the spleen size, can get in the way of activities, particularly in children, because of the concern about injury to the spleen related to it being enlarged. This information in the bar graphs on the right shows data from a focus group interviews with people who have pyruvate kinase deficiency and the frequency with which people reported certain manifestations. And that included jaundice at a very high rate, tiredness, fatigue, low energy, shortness of breath, many of the manifestations of anemia. I'm going to switch now to talking about treatments in pyruvate kinase deficiency. And I'm going to focus just on the supportive treatments because you're going to be hearing from Dr. Shah and Dr. Al-Samkari about other treatments in clinical trials or recently approved treatments. So what do we know about transfusions in children? Well, we know that ongoing transfusion needs can be difficult to assess in those first few months of life. I just mentioned that. So it's important to try to extend the time between transfusions to see what's the baseline hemoglobin. Can we get the reticulocyte count to be higher to raise the hemoglobin, and are there symptoms related to the low hemoglobin? We know children who are younger than 5 have the highest frequency of regular transfusions, 6 or more transfusions in a year. So more than half of children less than 5 will need regular transfusions, and that rate of needing regular transfusions goes down through childhood and then the teenage years into adulthood. And we think that transfusions are likely more often needed in younger children because that's a time before anybody would consider splenectomy. And splenectomy decreases the need for transfusions in most individuals, as Dr. Nathan mentioned. And also children often have a lot more viruses, a lot more symptoms from viruses, and then have hemolysis in the setting of those viruses and often need transfusions in that setting. What do we know about transfusions in adults and adolescents? Well, we know from the registry studies, what are the frequencies by which people need transfusions based on when they've had a splenectomy or not. So interestingly, we know that 10 to 20% of people with pyruvate kinase deficiency have never needed a transfusion. We also know that 25% of people have just needed transfusions intermittently, for example, in the setting of viruses or in the setting of an aplastic crisis, which is from a virus called parvovirus. And then we know that there's a big group of people who needed transfusions regularly in early childhood, then had a splenectomy, and then only needed them intermittently after that. And then there's about a 10 to 15% rate of people who needed regular transfusions, had a splenectomy, and then unfortunately still need regular transfusions where the splenectomy really didn't have benefit for them. And I'll just mention too that there are many reasons why individuals may choose not to be transfused, even though they have symptoms related to a low hemoglobin. And those include things like difficulties with IV access or intravenous access, not wanting to have a more permanent line to try to create access, the problem of how much time it takes to need to get transfusions, the financial burden of that, or challenges that they've had with iron chelation, because with transfusions comes this iron burden that the body doesn't have an easy way to get rid of. And some people may not tolerate iron chelation, or it may not be effective for them. So when do we consider transfusions? Well, it's different for everybody. It's very individualized. We consider transfusions when there's anemia with an impact on everyday quality of life, and that means something different for everybody. So that could be symptoms like fatigue, low energy level, not being able to participate in usual activities or get through the school or workday, having problems with concentration. All of those types of ththings could lead to a need for transfusions. We also transfuse in young children to promote and sustain good growth. I already mentioned that we often try to assess, well, does a young child need a transfusion? Can we get the reticulocyte count to be higher? Is it really affecting their growth or causing symptoms? We know pregnancy is a time that often transfusions are needed, even if they aren't prior to the pregnancy, to support fetal development. And then we transfuse in the acute setting when there's increased hemolysis in the setting of a virus, and people have more symptoms in comparison to baseline. But what we know is that that the decision about transfusion shouldn't be driven by a specific hemoglobin value, like we might see in other congenital hemolytic anemias. There's not a specific value, but we would say everyone needs a transfusion over that value, and no one should be transfused. Everyone should be trans lower than that value, and everyone should be not transfused if it's higher than that. That's not the right way, we think, to manage transfusions in people who have pyruvate kinase deficiency. And instead, we should be transfusing based on symptoms or complications somebody's had or other medical issues that they've had. So what do we know about splenectomy as a treatment? Well, Dr. Nathan talked quite a bit about that, and so I'll just talk about this briefly. We know it's historically been a common treatment for pyruvate kinase deficiency in 60% of people in the registry studies, a little more so in North America than in Europe. The average age is about 5. The hemoglobin after splenectomy on average is about 9, although it's pretty wide ranging, which you can see here from 6 to 12. It increases the hemoglobin somewhere between 1 to 2 grams per deciliter in most people, although it's difficult to tell if you've been getting transfusions before splenectomy. And the reticulocyte count increases in everybody after splenectomy. But we know, as I mentioned, there's this 10 to 20% rate of needing to continue on regular transfusions after splenectomy, that it's not effective for everybody, and that it's only partially effective. It only raises the hemoglobin to a certain degree. In addition, there's the possibility of complications, as Dr. Nathan mentioned, a 10% rate of blood clots after splenectomy lifelong, a 7% rate of serious infections potentially lifelong. And there's no change in bilirubin levels after splenectomy. So people shouldn't undergo a splenectomy for pyruvate kinase deficiency to try to change their degree of jaundice or scleral icterus, because it won't have that effect. And when we look to see, well, what are the predictors of a response to splenectomy, we know that people who have at least one missense PKLR mutation seem to have a better response, and those who have less of a hemolytic picture going into splenectomy also are more likely to have a response, so have a higher hemoglobin or a lower bilirubin level. So when do we consider splenectomy? As Dr. Nathan just mentioned, this is a difficult time because treatments keep changing. It's an exciting time and an important time. So it's a time really to pause, I think, around this decision to see, do you have opportunities to try other treatment options? Could you try a PK activator? Could you be a part of a clinical trial before you consider splenectomy? But before this, we considered splenectomy if somebody needed frequent transfusions, if they had symptomatic anemia. But we tried to avoid this in children younger than 5 because of the infection risk. We try to avoid it in people who are much older. And we always consider a full splenectomy because the reported people who had partial splenectomies, like we do in some other red cell hemolytic conditions, doesn't seem to be effective in pyruvate kinase deficiency, although it's a low number of reports. So what's important in someone who's had a splenectomy, Dr. Nathan already mentioned this, that it's important to consider antibiotic prophylaxis. We always consider this or always do this for at least a year after splenectomy. In pediatrics, we really recommend this for a lifetime because it's an ongoing lifelong risk of infection. It's critical to maintain your vaccines up to date. These recommendations change every single year. So every year you should look on the Center for Disease Control website about immunizations for special populations, which includes people who don't have a spleen, or ask your doctor, am I up to date on my vaccines? Because there's new booster recommendations or new vaccines that come along. And then it's important forever to have an urgent visit for all fevers so that you get an exam, a blood culture, and broad spectrum antibiotics, either intramuscularly or intravenously. Other things to know about splenectomy, Dr. Nathan also mentioned that it increases the risk of blood clots. And that's true for everyone who has had a splenectomy, not just in pyruvate kinase deficiency. And so it's important to consider a lifestyle that avoids additional risk factors for blood clots if you've had a splenectomy. And that includes things like trying to exercise, trying to stay well hydrated, avoiding smoking, and other risk factors associated with developing blood clots. And then it's important to consider whether you need to take preventative measures at times of increased risk for blood clots. And that can include times like pregnancies or after surgery where you may not be moving around quite as much, or long trips where you may not be able to move around quite as much. And then lastly, what do we know about stem cell transplant as a treatment for pyruvate kinase deficiency? We wish that we knew more, but there haven't been that many individuals with pyruvate kinase deficiency who've undergone stem cell transplant. So we can only draw on what we know from a very small number of individuals. I show here a worldwide effort from a few years ago to collect information about all the people who had undergone transplant for pyruvate kinase deficiency. And you can see this only collected 16 cases worldwide. These people were all transfused prior to their stem cell transplant. Typically, we would consider transplant in somebody who had a fully matched sibling as having the best possible outcome after transplant. This was a bit of a mixed population. The follow-up was about 2 years. And in this population, there was a high rate, almost 40%, in people who developed a new problem after transplant called chronic graft versus host disease, which is a new ongoing chronic problem related to sort of a competition or disagreement between the new bone marrow and somebody's body. And in addition, there was a lower overall survival, looking at 2 years of 74%. The graph shows that the outcomes were better if somebody was younger than 10 at the time of transplant in comparison to being older than 10. But this data is quite limited, but still brings us pause on making any recommendations around transplant in pyruvate kinase deficiency. And so most people generally would recommend transfusions, consideration of splenectomy in the absence of these new treatments, and then, of course, the consideration of these new treatments. So what are some of the potential complications of pyruvate kinase deficiency in children and adults? I'm just going to highlight a few, including iron overload, bone density, and gallstones. So why is it important to monitor for iron overload and pyruvate kinase deficiency? Well, iron overload always occurs in transfusions, as I mentioned, but it also occurs in people who don't get transfused or who have received very few transfusions. And it occurs in most people with pyruvate kinase deficiency, regardless of their age or their gender. And we can monitor for iron overload fairly easily. So one way is with ferritin, which is a blood test. Another way is through radiology tests, including an MRI study, which is what's shown in the picture here. Or through liver biopsy, which is the most invasive test, but was the historical test for how to measure iron overload. And iron overload can be managed with iron chelation, which is another reason to check, because you can get right on top of it with medication. But if it's untreated or under-recognized and therefore left untreated because of that, it can cause damage to the liver or the heart or hormone-producing organs in the body. And so with our most common test is called the ferritin test. That's a blood test that people should have regularly who have pyruvate kinase deficiency. And the question is this a good test for iron overload? Because we have those other options. And the answer is both yes and no. So this figure shows people's ferritin on the x-axis and their MRI results on the y-axis. And you can see there's this nice line that sort of correlates and makes it look like the ferritin and the MRI are well matched, and they are. But on an individual level, it's not always a good match. So the people who are in red dots on this show those people who have a ferritin less than 1,000, but still have evidence of iron overload by MRI. So this is why we recommend an MRI study, if you're able to get one, to see how well the ferritin correlates with that MRI study, which is really a more robust study of iron measurement. What do we know about gallstones and pyruvate kinase deficiency? So we know that people have generally a high bilirubin level. It's generally between 2 and 6, but can be much higher than that, especially if somebody has co-inherited Gilbert syndrome, which is a slow metabolism of bilirubin. It's not a generally in a clinically important or significant finding in terms of causing a disease or causing problems, except it leads to a much higher level of bilirubin in people who also have pyruvate kinase deficiency. And we know that elevation in bilirubin leads to this increased risk of what's called pigmented gallstones that are made up of bilirubin. And that's at a higher rate too in people who have Gilbert syndrome also. So having this combination of Gilbert's and pyruvate kinase deficiency is common because Gilbert's is common, but leads to this high bilirubin and a much higher rate of gallstones. And we know that the rate of gallstones varies by age and is quite common. And we know that splenectomy, because there's still red cell breakdown after splenectomy, doesn't decrease the risk of gallstones. So it's important to know about this risk, to know about symptoms, including significant abdominal pain, especially after eating certain foods, or back pain, and to potentially have screening if you have a gallbladder, and especially if you have any symptoms. And what is the effect of pyruvate kinase deficiency on bone health? Well, this is just more recently recognized that there's a high rate of early onset of low bone density, osteopenia or osteoporosis, they're called, in people who have pyruvate kinase deficiency. And this was really recognized through work in the clinical trials where DEXA scans or bone density scans were being done as part of screening for completely different reasons. And it was recognized that there was this very high rate of low bone density. This figure shows DEXA scan results in the people who are in the middle and on the right have low bone density in their spine, where they would potentially need to take supplements or medications or have a certain exercise regimen to try to help their bone density. And so it's important to have regular screening for this now that we've recognized that this is a problem in people who have pyruvate kinase deficiency. And just a last few notes about pyruvate kinase deficiency before I finish up. We often are asked, well, can we categorize severity? If there's a new baby who has pyruvate kinase deficiency, if we know what mutations they have, what does that tell us about their future? What does that tell us about their risk of complications? And I wish that these were better predictors or that we had better predictors. This table shows the different genotype combinations kind of grouped into big categories. The group all the way on the right is called missense. Those are two of the more mild mutations. And the group on the left is called non-missense, the two more significant gene changes. And the group in the middle has a combination of the two. And you can see that the people who have two more dramatic mutations have a younger age of diagnosis, have a lower hemoglobin, have more transfusions, a higher ferritin, higher splenectomy and iron overload. But you can see that the people who have two more mild changes, the two missense mutations, have all these issues too. And so we know that if there's two more drastic mutations, that there's a higher likelihood of these complications, but that the complications really could occur for anybody. So while this may be helpful a little bit, it really doesn't help you in terms of who needs to be screened for different complications, for example. And then we tried to look too, if you need transfusions versus if you don't need transfusions, is that a marker of who has a higher likelihood of having complications? And this too didn't seem to help to categorize people, really probably because it's a more subjective, individualized decision about deciding to get transfused. And we saw that the hemoglobin was the same in the two groups, the pulmonary hypertension was the same, and all these other complications except for iron overload seem to be the same between the two groups. And so it's our registry studies that have led to some guidelines about monitoring in children and adults. And I've listed here some of the monitoring that we consider. This is not evidence-based. So I would say, one of the topic I was given to discuss with you today was about guidelines in pyruvate kinase deficiency. And we don't have guidelines for pyruvate kinase deficiency. The exciting news is that these are just now starting to be developed. We're working on evidence-based guidelines, they're called. So looking rigorously at what we know based on people who've had pyruvate kinase deficiency, based on what's reported in the medical literature, and making guidelines based on the evidence. These are expert-based guidelines. So these are things that generally people who take care of patients with pyruvate kinase deficiency would recommend. And so for children, this relates to how often to check certain lab work, including blood counts, reticulocyte count, and iron studies. The iron studies depend on whether you're transfused or need chelation, checking in about height and weight and pubertal growth. Looking at liver iron concentration, as I mentioned, thinking about MRI studies in the non-transfused individuals, once you could have a non-sedated study, for example, because it's difficult to undergo MRI at a young age without sedation. And for people who are regularly transfused, we typically would do this after 10 to 14 transfusions. Thinking about an ultrasound to look for gallstones, bone density in teenagers to see if there's been an effect on the bones, and then in people who are transfused, doing infectious screening. And then just to mention too, in children and adults, the importance of mental health screening every year because of the effect of pyruvate kinase deficiency on everyday life. And this similarly goes through the monitoring for adults as well. So just to end here with some concluding thoughts, I just want to say that you know yourself the best, you know your child the best, your family members the best, and you are the best advocates in terms of knowing how pyruvate kinase deficiency affects you. And it's important to tell your care providers and your clinicians about how pyruvate kinase deficiency is affecting you so they know how best to address your needs. I mentioned evidence-based guidelines are underway, which is exciting. I already mentioned too that data from natural history studies is really key to being able to make guidelines around monitoring and around care and to help inform clinical trials to make progress in new treatments for pyruvate kinase deficiency. And of course, collaboration is key to medical progress. This event is a good sign of that collaboration in terms of industry, patients, and physicians and clinicians, and your voice is just critical to making progress. So thanks very much for your attention, and I look forward to the panel discussion.